I'm going to introduce Kathy Lindell, who actually I've only known, believe it or not, for about a year and a half, because I feel like we're kind of lifelong friends after this short period of time. But Kathy also has a very impressive background, and she has a PhD in nursing, which I'm always, again, very impressed with people who are at a doctorate level in nursing. So she's at the University of Pittsburgh, and she's associate professor there. She, I think, as you might have gotten the drift, that she has a slight interest in palliative care. Again, I've been able to do some work with her as far as the videos, and she's very passionate about getting patients involved very early in palliative care. So thanks, Kathy.
And I thought it was more like 25 years. We were friends.
Yeah. Actually, I have to add, too, that so she says that she's been doing this for 41 years. So just, if I said, I don't know how she had them in.
They said I was a candy striper.
That's right.
So thank you for this opportunity. And today I'd like to speak about the challenges of ILD management and specifically talk about palliative care. And is this? Okay. So by way of disclosure, I currently have a grant from the National Institute of Nursing Research looking at integrating early palliative care for patients with IPF and their caregivers. I'll talk a little bit about it towards the end. I have a grant from Three Lakes Partners, and then I'm on the Genentech ILD Nursing Advisory Board. So by background, I'd like to tell another personal story. So this is Frank. Frank is one of our patients. Frank was so proud of himself, he brought this picture to Deb in pulmonary rehab, who she quickly shared it with me. So this is a typical Western Pennsylvania yard, a little bit of slope, and there's Frank on 15 liters of oxygen with his E-tank jerry-rigged to his gas lawnmower. And he was so proud of himself. Like, he's like just a hardy Pittsburgh guy. Like, so we all have Franks in our population. So the key with IPF is it comes out of nowhere. I like to say yesterday they were fine, and then all of a sudden today they get this tragic diagnosis. They often have difficulty recognizing the disease magnitude, both the patient and the caregiver. And as mentioned earlier, the progression varies, but we know that the median survival is 3.8 years. So this next picture is Frank on the right, 8 months post lung transplant. So Frank is with two of our other patients who also, the gentleman in the middle is 5 years post, and the woman on the left is probably 3 years now. She has also had a kidney transplant as a result of complications from her meds. But I put the bias out there right up front. I'm a big advocate for transplant because, as a patient said to me long ago in a support group meeting, so you're telling me with IPF it's pretty likely I'm going to die. And I just let them continue talking. But if I got a transplant, I can extend my life. And I said, that's pretty much it. So I advocate for early referral and always say that it's better to be told you're too well, because we know that if you get your transplant evaluation and you're deemed too well, you're at least on their radar. We can't predict how the disease will progress, and what happens is that these patients fall off the cliff, and then they decide, oh, I want to get that transplant evaluation, and it's often too late. So that's my 2 cents about that. So as mentioned earlier, there's these several possible disease courses that our patients may experience, and I think the most challenging are these patients who die within the first year that we see them. And then it's confused by these patients who may linger for 10 to 15 years, and you want to think, is it truly IPF? But we're going to talk about that. So I'm going to introduce this term that's relatively new in the literature for the past few years, progressive fibrosing interstitial lung diseases. And these, we'll show a picture, but this is a pretty hot topic. And so what happens in these PF-ILDs is that the natural history of the disease is characterized by a decline in lung function, worsening of symptoms, health-related quality of life, and early mortality. And the predictors include a greater impairment in their FVC or DLCO, a greater extent of fibrotic changes on their CT scan, and as we mentioned, their disease course is unpredictable. And if you take a look at this cartoon, so progressive fibrosing ILDs is in the center in the orange. And then around the outside is just the general term of ILDs. But there are these different specific diseases in there. HP, autoimmune ILDs, exposure-related, sarcoid, IPF, the other ILDs, and the non-IPF IIPs. So all of these patients have that potential to have that disease course that has that exaggerated decline. Now, this slide, just imagine if you're looking at that right side, it goes up one. Something happened in the transmission. So we know with PF-ILD that patients experience a shortened lifespan, and if you take a look on the right column, those are papers that go into more detail. It's surely not just these papers, there's many others, but these are typically the main ones. Patients experience a variable disease course. They have tremendous symptom burden. It's a huge impact on their caregivers. There's limited treatment options. They have a need for supplemental oxygen and then a need for palliative care. Patients experience this myriad of symptoms. So if you take a look at this, they experience shortness of breath, cough, fatigue, deconditioning, depression, anxiety, and all of these affect their quality of life. So the role of palliative care emergence. So this is the World Health Organization definition of what is palliative care. And it's an approach that improves the quality of life through prevention and relief of suffering, early identification and impeccable assessment and treatment of pain and other problems. And the focus is on these two things: symptom management and addressing advanced care planning to improve quality of life. So someone earlier said, it's really kind of hard to bring up that word palliative care at that first visit. And so what I'd like to challenge you is palliative care is really about improving quality of life. We know that many of these patients get to us, especially at specialty centers. If you're at a specialty center, they get to us late in their disease. And so I suggest that we're interested in what can we do to improve your quality of life. So palliative care is really improving quality of life. And there are things that you're already doing in your practice. You're refining their oxygen. You're sending them to pulmonary rehab. Those are things that are considered palliative care. And we'll go into more detail, but I just want to, congratulate you because you're already doing that, and you may not think of it that way. There was this study done in 2013. It was reported by Temmel, and they did this study. This really kind of changed the current. So they looked at palliative care with patients with non-small cell lung cancer, and the purpose was to examine the effect of palliative care integrated with standard oncologic care on patient-reported outcomes in these patients with non-small cell lung cancer. And their hypothesis was patients who received early palliative care compared to those who received standard oncologic care will have a better quality of life, fewer depressive symptoms, and less aggressive care. They randomized 151 patients. 107 completed the study. 27 died during the interval, and the remaining were lost to follow-up. But in those patients that were assigned to early palliative care, they had a better quality of life, fewer depressive symptoms, less aggressive care, and they lived longer. So this really kind of changed the current for how we think of palliative care, and we need to be doing this more. So then this is actually a very interesting study here. So I'm sure you've had that patient who, when you've seen them in their initial visit, they'll say, "Oh, thank God it's not lung cancer. I was so worried you were going to say I have lung cancer." Well, newsflash. If you take a look here, This is a comparison of 5-year survival for IPF and different forms of lung cancer. And if you take a look here, here's IPF, and when you compare, I have to actually move here. Okay, so when you take a look, so lung cancer, the survival rate isn't that much better for IPF. In fact, it's worse. And some researchers and clinicians actually think of IPF or PF-ILD as maybe similar to something's going on that is similar of an oncologic nature. Okay, so palliative care and chronic disease. This study was done by Biernot in Europe, and they took a look at those patients that were prescribed palliative care with chronic disease. What they found for patients with COPD, 20% were referred. Patients with heart failure, almost 35%. Patients with dementia, 37%. And patients with cancer, 60%. And that we have a lot of work to do to actually improve this in non-malignant lung diseases. Last year, the Center to Advance Palliative Care, which is based out of Mount Sinai in New York City, they reframed the definition of palliative care. And it's the act of bringing people together to ensure that all those with serious illness receive the care that they need in the right place at the right time. And they reformatted this graphic here. I don't know if you remember, the old one used to be just a straight line, a diagonal. But if you take a look, this is any serious illness, and PF-ILD, IPF, any of the pulmonary fibroses, these are serious diagnoses. So at the time of diagnosis, it is totally appropriate and that palliative care is mentioned, advocated, and it's alongside disease-directed therapies. And as you take a look, see the curvy line, because every patient's story is different. There will be those patients that progress quickly. There will be those patients that have a longer disease course. So how does this differ from hospice? Hospice is provided, or should be provided, when a patient is thought to have 6 months left to live if their illness runs a normal course. It's focused on comfort, pain relief. The patient forgoes aggressive treatment and can be reevaluated regularly at these 6-month intervals. But the important takeaway message is there's no time limit on how long a patient can be in hospice. And I like to tell the story. We had a patient several years ago who he didn't have a caregiver. He lived by himself. He was a retired military person who he had this Airstream that, trailer that he lived in, and it was really pretty souped up, is the best way to describe it. He was on 15 liters of oxygen, and anyway, what happened is that there wasn't really much more that we could offer, so our doctor prescribed hospice. Well, he did so well because they provided comfort and pain relief that he lived for 3 years. So it was renewed for 6 more times. Now, yes, that is that's not a normal story, but the important takeaway is that when you can provide these services to help promote the patient's comfort, quality of life, give them medications to help them breathe better, help take away their cough, all these things promote their quality of life. Now, it gets a little confusing. So I've already told you you're all doing palliative care of some sort when you do the things that you do. Now there's primary palliative care and there's specialty palliative care. So primary palliative care is delivered by the clinical care team, so that's you. And then specialty or secondary palliative care, that's delivered by the interdisciplinary team. So think in your institution. Most of you, well, how many have formal palliative care services at your institution? She's saying inpatient only. How many have outpatient? Okay, great. All right. Optimal palliative care for patients with chronic lung disease, such as ILD, should really incorporate both primary and specialty. One of the biggest challenges for patients is that you take care of them, you see what they have to come with their oxygen, and it's a lot of oxygen. And to add another appointment is sometimes very challenging. So it's really important that the two work in concert together. And then just to add the caveat, there's a national shortage of specialty palliative care providers, so it probably will fall back on you. And there was a study done that patients prefer the term supportive care compared to palliative care. They don't know what palliative care is, they just don't like the word. So supportive care or quality of life care is a better way. It's more acceptable. So this is that study that we're finishing recruiting for in Pittsburgh. It's a randomized clinical trial of an early palliative care intervention entitled Support. So Support it's a book that I wrote, and it's really pretty simple. And it's all the things I personally think that every single patient with any chronic lung disease should get. We'll go into it in a little more detail, but we're studying it in patients with IPF and their caregivers. So it includes information about the disease, self-management strategies, and introduction to advanced care planning. It's registered through the University of Pittsburgh Innovation Institute, which is actually, for a nurse, that's one of my highlights of my career is I have something that it has a trademark to it. And I would promote every single one of you because you do this in your life. And your trademark would be, how do you do that letter to help us? So and the content is available across multiple domains. It's delivered currently by a nurse interventionist, but it's printed material, and we have it available on a digital website. So this is what it looks like. And this is the content, what it breaks down to. So it's symptom management, understanding your disease, pulmonary rehab, palliative care, oxygen therapy, research opportunities, and transplantation. So this book describes all of these things in the content, and our nurse interventionist, if the patients get randomized to receive the intervention, she sits and she reads the book to the patient and the caregiver. And it takes approximately 15 to 30 minutes to read it. And it's broken down into 4 parts, but she reports back to me that everyone wants to finish it at that setting. So we haven't had anyone that has said, stop. This is uncomfortable. She said it's actually been, for some of the caregivers, it's made them teary because it addresses the serious nature of this. Our target is 80 patients and caregivers, and we're at 73 right now. So we plan to finish December 18th. I think the important takeaway here is that palliative care has different names. So palliative care, supportive care, quality of life. Our goal is to help you achieve your best quality of life, and this is one of the pages in the book. So resources. How do you find a palliative care program? These are 2 websites. There's non-hospital-based programs. If you go to caringinfo.org, you can type in your state or your zip code, and it'll tell you what's available near you. If you want to find a hospital-based program, you go to this getpalliativecare.org, find a palliative care team. One of the other resources that I think is really important are the visiting nurses. There have been many times that we've utilized the local visiting nurses because you have that patient that's just quite not ready to, they're in the trajectory of understanding the serious nature of the disease, and we try to see if we can get a visiting nurse in that home to see if there is some kind of home care need, and sometimes home oxygen will qualify to get them in there. But then they develop a relationship with the nurse, and the nurse is actually able to segue into hospice services. So visiting nursing is a great resource. Complementary resources. So for patients, if I'm not sure if you're aware of this, but on the Pulmonary Fibrosis website, Foundation website. There is a series of 12 educational videos. This was done last year. And there's one on what is palliative care, and that's for patients. And then for providers, Global Academy came to us last year with Pauline, and we did this video. It's a 30-minute video reframing palliative care to patients with IPF, but the target audience is clinicians who take care of these patients, and you can get CME for this. And this is that, I mentioned this resource, so the pulmonaryfibrosis.org, here's a picture of Dave Lederer, and there's these series of 12 really good resources. So one of the things I want to reinforce to you in your daily job, we know everyone's busy. We know you're being bombarded with the authorizations and the oxygen. And there are really good resources here, and the PFF is not paying me to endorse them. But I just feel very strongly that these are vetted and created by experts. It's here, use them. The other thing that they have is an 800 number. It's to their call center network. You know, you have those patients that are chatty, and they want to talk to you, and you're trying to get your auths, you're trying to see your patients, you're trying to get through your day. This is a really great resource to send your patient to this, or their caregiver or their family member, to get more information. So I highly endorse that. Now, every year, our mantra at our center is we want our patients to live with IPF. So we host an annual golf outing. This is this year's golf outing. And what happens is patients can golf for free. If they don't golf, they play bingo in the afternoon, they have a free dinner in the evening. But it's really just a day of fellowship and getting out there and knowing what they can do. And it was actually started by one of our former patients who said to me at a support group meeting, if you ever need a fundraiser, I have a golf course. What you make is yours. This is the 15th annual this past year. He has since died, but his daughter is one of she kind of like helps to keep us straight and on the narrow of how to do this. But I think this is the most important. So we all have those patients who are depressed, anxious, and are just very sad about this change in their life. But I like to tell this story of Joan. And Joan knows that I take her and present her, and she always like, where'd you take me last time? Where have you taken me? But Joan got the diagnosis of pulmonary fibrosis, and she has one of the CT-ILDs, but it's pretty serious. She got the message when the doctor told her, and she came out of the room and she tells the story, you know what, this is pretty serious. There's still a lot of things on my bucket list that I want to do. So she went to Australia, and she had the resources to be able to do it. But so here she is dancing with one of the natives with her portable oxygen concentrator. And so the takeaway message is that if you can get the patient to get on that, we don't know how your disease will progress. We can help you achieve your best quality of life, but you got to just keep moving forward every day because there's no ticket on when it's done. So thank you.